Hey everyone, welcome back to all my listeners. Now, if it's your first time finding me, thanks so much and welcome. Now, I hope you're all having a great day so far. I know I am. Now, you know what? Still the month of March, and it's full of March Madness. That's right, basketball, March Madness basketball is in full swing. Now, there were so many upsets on day one and day two of last week. It was complete insanity. All of our brackets across the nation were busted. So, you know what? I just made myself some more. And I'm so very looking forward to all of those Sweet 16 games on Thursday, the day after this podcast drops. I've missed my March Madness basketball for these past couple of years due to the COVID-19 coronavirus pandemic. But my basketball's here, so I can't wait. I'm so happy. I think you can all hear it in my voice. So anyway, you guys, welcome to my 12th episode of Season 5. Today is Wednesday, March 23rd, 2022. My name is Sonal Patel, and this is the Paint the Medical Picture podcast series. Now, all right, guys, I'm going to be diving into my compliance tip today and sharing some details on the new modifier, FT. That's F as in Frank, T as in Tom. And I'm going to continue part 2 of my red carpet interview in my very special guest interview with Kate Patskovska. And of course, I close out today's episode with some inspirational words on clarity and focus from Zig Ziglar. If you've checked me out on LinkedIn, you know I'm all about compliance and protecting our physicians and our valued healthcare professionals when it comes to the business of medicine. I hope this week with me brings you enough to take back to your organizations, to want to dive in deeper, to use my tips and best practices to ensure success. I hope this podcast will help you boost the quality of documentation capture and improve coding accuracy as you help your providers paint the medical picture. If you like what you're hearing, please go ahead and hit that subscribe button now so you don't miss another episode. Please write in a review and kindly drop me a 5-star rating on Apple Podcasts or wherever you listen to my podcast. I'd really love your support. And as always, a very friendly disclaimer. Remember, I'm bringing you the news, current healthcare industry news, my compliance tips and my recommendations based on my over 10 years of experience in front office, in back end, in coding, and in billing for multi-specialty physicians, in compliance, and in auditing for both E&M and surgical operative reports. These are my opinions alone and are not to be construed as legal advice. Spot on. Well, we agree there. I love it. I love it, Kate. Perfect. Now, let's move on to my next question, right? Because this is where I want to uncover your tips, right? Now, you know that I'm all about working smarter for coding compliance and affecting change, real change in this space of healthcare. But I want to hear your voice and what your thoughts are. Can you provide my audience with your top tips based on your experience for successfully billing for providers of all specialties?
Oh, absolutely.
What are your tricks? Yeah.
My number one trick is basically training the front staff. It gets overlooked because all the time the provider thinks, well, I get a receptionist and I'll just, schedule, we check eligibility. However, registering the patients, putting the proper information, data entry, verifying not only the eligibility and making sure that the patient actually has the insurance, but also training them how to look at the benefits and how these benefits apply and financially affect the treatment, whether or not the patient has a copay, whether or not the patient has a co-insurance or deductible, for example, too. Because recently, for example, in allergy world, a lot of testing is going towards diagnostics, quotes unquote. So they will say, and even though it's not a lab, you're doing the test in the office because there's a separate code for that. However, you are still using, as for diagnostics. So the patient might have a copay, just for the visit. And then they might have a co-insurance or a deductible might apply towards those diagnostic testing. And the front staff has to realize that they are the first line of defense. They're the ones who have to make sure that all the information that is presented here and then forwarded over to the biller is proper, because again, the biller can put in the codes. It's not a big deal. You know, you look it up, you see what the provider has, or the physician has performed services. But if that information, the benefits, eligibility, and everything else is not captured by the front staff, then it creates a lot of backlog. Number one, it creates patient dissatisfaction, because now the patient says, wait a minute, I thought I had only a copay, and now you're telling me I also have to pay a deductible towards this, or whatever the case might be. And it also creates that disruption of money coming into your office. So again, all of this, so having them looking at all of this eligibility and benefits, it is extremely imperative for the front office. The other one that I have seen a lot too is a date of birth rule. For example, if it's a child and the parent, both of the parents have insurances. We had a situation where the parents were divorced. And unfortunately, the child was under the father's, but the father was under the impression the child was under the mother insurance. And they actually, they had both the same insurance. So the same carrier. And we had a situation where the payer was, well, we're not paying you because the COB is not updated, the coordination of benefits. So who do you put first, the mother or the father, you know, and all of those things. And it took them about a whole month to sort everything out, but that's only because it's $11.99 and the insurance payer is taking a long time to, you know, to sort it out. But it was a long time, about a month, until both of the parents had to contact the insurance to let them know what was going on. Because again, the child is a minor. So this is also one of those things that I try to train the front staff and let them know that this is what you need. The second thing that I usually do is review code changes and see if any of those apply to your specialty, because there are some, like allergy, for example, they haven't changed. You know, you're using the same codes all the time. The amounts could have changed, you know, that the insurance will cover or pay for. That's where the reimbursement policy comes in. But a lot of times the code sets itself does not change. But cardiology, for example, changes all the time. Orthopedics changes all the time. DME changes all the time. And that's not just on top of my head. ENT even changed also. Some of the presentations that I have done, they have the new code sets, or you know, dermatology, some of the codes have changed. I had one where it was about a breast cancer, for example, screenings and stuff. And I think 2 years ago, they completely changed, removed all of the other codes, and then gave a completely new set of codes with better definitions and everything. So I let the provider know, you have to update your sheet. Which codes are you using? Which codes are you not using? And somebody, part of your staff members, they can just go and look into it, especially if you're certified. You have the books, you have access to APC, for example, Codify or something else, and you can look up and say, okay, has anything changed for our specialty? And it helps you to be compliant, because again, if you are not billing the wrong code that already expired, then you are not getting a denial. So again, you're setting in the proper information the first time. Then we're looking at denial management, and this is where I also look at to see whether or not they have a denial management procedure process. What do you do? What is your process, the procedures? What are you looking at first? Are you really following, you know, when you get certification, you study in the course, they tell you how to do the ARs, you know, the RCM, the revenue cycle management. But if you don't practice it, after a while, you forget it. So sometimes I would ask the office staff and say, well, what do we do? If I had a client, for example, who had $2 million outstanding ARs.
Oh my
and
goodness.
I'm like, wait a minute, what happened here? You know what I mean? Like, why is the number so high? What is going on? Who is, who's looking at this? And we also look at the EHRs, because EHRs, EMRs, they're supposed to help us identify certain parameters. But I have worked with eClinical, Cario, Practice Fusion, and some of them, they don't do that. They don't identify those particular trends. So you yourself have to have a procedure. What are your steps on denial management when we're having that? And do you have a person who's designated for that? Do we have that? If we don't, then we have to train somebody and then write the procedures, and then, and let them know that this is what we're going to follow. It could change every 6 months, just to tweak it out and say, okay, well, this doesn't really work out. It takes me a long time to do this. Give a feedback, because nothing is written in stone. That's my philosophy. Nothing is written in stone. You don't have to follow those stiff rules. If you need to change something and it's easier for you, because you're the one who's doing the process, if it's easier for you to change something and it makes it quicker for you to go through the claims and do whatever it is needs to be done, do it. Write it out again, add it in there, have it have fluidity. You know what I mean? Because a lot of times, that's another thing that I have noticed. The physician says, oh, well, my colleague has this, and this is what we're going to follow. And I said, yeah, well, it might work for that office, but it might not work for us, because we only have 2 people here, you know what I mean? And the other office has 4 people. And again, so we don't have that availability of hands on deck per se to actually follow through on what they were doing. We have to look at it and then add it or subtract whatever it is that we don't need. And then again, what happened with the ARs? Why do we have this amount, and identification and everything else? And so that's another thing that I always look at to see. And unfortunately, a lot of providers who are either by themselves or they have only another partner, they usually go into business hoping, oh, I'm going to make money. And then not realizing that there are so many other aspects that they have to do. And they completely skip this step, which makes it difficult for them, because now 6 months down the line, you're hiring an outside person trying to go into your system and trying to figure out what actually happened. But if you would have trained your staff on this, then you wouldn't have to go through this, because your staff would have had answers, and they would have said, okay, I went through the ARs, 6 months, whatever, this is what we have, this is what we can collect, this is what we can't, and then give a progress report. One of those jobs I actually had and gave me fantastic experience was in 4MA urgent care. And I have to tell you, I absolutely loved that experience, because whatever could go wrong, it went wrong there. Yes, absolutely, 100%. There were a lot of issues regarding the business registration for this particular urgent care. And another aspect that we had that physical therapy business with that too. So there were a lot of denials. There were a lot of other issues there. And I believe hands-on experience, I mean, education is great, don't get me wrong. You always want to say, I am certified, but having that experience of actually doing it with your own hands and saying, hey, I did this. And you know what? Oh yeah, I remember this is a case also. And then you apply that towards the other businesses and say, no, I worked with somebody who had everything wrong there. And now we are here, so I'm helping you to be better. You know what I mean? So I definitely look at denial management as one of the things that you definitely need to have in your practice. It will help out everybody and make it easier for you and your staff, again, to address those denials. And the last one that I have noticed was prior authorizations. So everybody dreads them. Nobody loves prior authorizations. I love prior authorizations. People say I am crazy, but I love prior authorizations, because prior authorizations tie into reimbursement policies and medical policies. You have to really be a biller and go into the systems with these research to try to figure out why we get in a denial, or why the authorization is this, or whatever the case might be. I have to say, and I'm not tooting my own horn here, but I deal primarily with prior authorizations for specialty medications, and we have a 95% approval rate. The other 5% is something that maybe the patient really doesn't qualify for that particular medication, but they might qualify for another allergy medication or whatever the case specialty medication is. And part of that, again, is reimbursement policies. And so my provider will tell, the physician will say, okay, I have this patient. I think they will qualify. What kind of insurance do they have? Okay, this is what they have. Does it go through medical? Does it go through pharmacy? So that's another thing that you have to look at. Yeah. And which codes can I use? Can I use buy and bill? Can I do buy and bill here? You know, that also applies to it, because you have to know which codes you're supposed to bill on the claim. So, and the other thing that I also realized is that just because you have an authorization, quote unquote, I love paper. I love to get a fax back. Don't give me over the phone, because sometimes what happens is that the office staff will call on the phone, try to give them the information. They get what they call a predetermination authorization number. And then the physician thinks, oh, we're already good to go.
We're good to go. No, that was just the first step, right?
Right. And I tell them, no, we have to send in the medical records. We can't just give them this information. So I'm a big proponent of make sure you give them more than less, you know, and give them the most recent information. So if they are looking for the last date of service or 2 last dates of service, they're looking for 2 tests for the patient, give them 3 tests for the patient. And I also like to highlight, because what I have noticed, and especially in the last 2 years with this pandemic, is that whoever is processing these prior authorizations requests, they don't really look at the information. They only skim through it. They look for only specific guidelines that maybe the insurance has, and then that's it. And then they say, okay, it's denied. But I say, but wait a minute, but according to your policy, this patient, I sent you this information. And, you know, the pharmacist doesn't call me. It's somebody else who calls me, who then gives that information to the pharmacist. It's just too many people touching all this paperwork. So if you and your staff are organized in the office, it makes it so much easier, because again, you know what you sent over to the insurance. You have highlighted all the things that they were looking for, and you can't say, so when they call me and they say, oh, I don't see this particular thing for the patient, I say, wait a minute, I'm going to go into my paperwork, pull the patient up. I said, no, page 14. It's right here on the bottom underneath with a plan or a procedure or whatever. I have, you know,
and you've highlighted it, You've pointed it out for them to see it directly and clearly. Yes.
Correct. And that just proves to me that whoever was processing it originally had,
wasn't looking.
They just skimmed through it. They weren't looking to see, because remember, each EHR has a different output, I guess, of how they put the information into the medical records.
That's true.
So I could have a plan, for example, last, but maybe clinical has it in the middle of the middle.
Correct. That's a great point. Yes.
So, you know, again, they're not going to read every single page, especially if you're sending 15 pages to them, you know, via fax or attachment or whatever the case might be. And then, you know, they're not going to look through all of that. So I like to just circle it. The same thing I do with denials when it comes to prior authorizations. months. We had situations where we did get the authorization. I did send them. The patient does qualify, but then they say to us, oh, it's investigational. No, it's not.
Don't you hate
Let's
that?
look at your reimbursement policy.
Right.
Let's look at your codes.
Yep.
Yes, I do qualify to bill this code.
Mm-hmm.
And the patient, according to your policy, I don't print out the full policy. What I usually do is I read the denial reason why they did that and specific code.
Right.
And then what I do is I go to their policy and print that particular page. And then I circle it, point at it, and I said, wait a minute. And then I write a letter to them. I will never forget, I had one letter from a medical director that wrote, well, like a medical director is, I'm going to be scared. I'm not scared.
Right.
And, because a lot of times also what I have noticed is that these medical directors, they just have an MD, but they might not be a specialist in that particular
field. I agree. I agree.
It.
Correct.
It drives me crazy.
Yes, it's very annoying.
A lot of physicians, when they see that, they get angry, but a lot of office staff, they get intimidated because now they say, oh my gosh, it's a medical director. They reviewed it. They're not going to pay us, No, all you have to do is write a nice letter, put the package together. And I remember this particular patient, it was 7 months. It took me 7 months, but I was able to pay all the claims.
But you fought. Exactly. You have to have the gumption to fight. Yes, you can't just roll over and say, oh, well, this medical director said, no, I'm denying everything, and just agree.
Yes.
I like seeing that in you, in people that are passionate about fighting for the patients, right? We can read the medical policies ourselves. It's not experimental or investigational. You have the policy that qualifies the patients, right? If the medical necessity is met, and it was met in this case. And yes, you had to fight for a long time. 7 months is quite long, but the patient got what they needed in the end. And that's what counts.
And that's why I say it's betterment for the self when it comes to training, because then the office staff understands that they're not powerless.
Yes, good.
They have to understand that I have rights. I have the right to appeal this, whether it never got to external appeal. So this was still like a second level internal appeal.
And it was resolved.
But I already knew that this would, it held no water. It basically had nothing to do with, the proper denial. The patient did qualify for this. And then, or like you said, also the patient sees because now they have the accessibility to go online and see whether or not they owe any money with the EOBs. And that's another thing that I also try to do is try to teach the patients that EOB is not a bill, okay? EOB is just a summary of the information that we have done for you, and then that's it. You paid me your copay, you're okay. You don't owe me anything.
You're done, right?
And in this particular case, they were trying to say that the patient owed over $13,000 for that particular medication. And the patient was, oh my goodness, do I owe money? And I was like, no, you don't owe me $1 and you don't owe anything to the pharmacy either, because we are going to fight for this.
We're going to fight.
We are going to send this over to the insurance, and I don't care how many medical directors have to write to me an answer, but we are going to write it in a nice way. I like to also include in my letters the timeline of all the phone calls and the letters that I have sent over. Perfect. So in my letter, I will say, okay, well, at this particular date, this is when it started. I called to verify on this claim. Then this is particular date, this is what we have done, and go from there. And when you teach the office staff to do that, and then you try to explain it also to the provider, to the physician, and again, they're all on the same page. And that's one of the things that when I do my presentation on denial management, I try to give the most updated information. And I always tell the whoever is attending my presentation, I always tell them, you have to know the timely filing because they change. For example, for Medicare, we have a whole year. However, for the Medicare Advantage plan, some of the insurances like Blue Cross Blue Shield, for example, they changed it. I think at first it was 180 days, which is for the commercial. Now it's only 90 days from the date of service.
Yep.
So if you don't address that particular claim
Yep.
within that particular time frame, and even for the second level, that's another thing too,
Right.
is that people have to understand that it's not only from the first time that you actually try to address the issue, but it's the second level or the external level.
Right.
Every single step has their own timely filing. And if you're not familiar with it and the insurances change it, and then you have the in-network and out-of-network, and what one of the payers did here is that they made it universal. If you're in or out of network, it doesn't matter. It's the same number of days. I think it's 120. And they changed that right before the COVID happened. And again, if you're a provider who's out of network, you're not really looking at that because you think it doesn't apply to me.
Right.
I have a whole year, no problem. But then when you get a denial and saying that the claim was not addressed in the timely filing, now you're like, oh my goodness. And guess what? You cannot appeal that.
Right.
You're stuck with unable to collect the money from the insurance or from the patient, because the patient had nothing to do with that. The patient already paid their copay or co-insurance or deductible. You know, it's the insurance situation. And if you have properly trained staff, then you know what's going on. So those are the 4 things that I look at to have a successful, just off the top of my head, but to have the successful practice for any physician. If they address at least those 4 basic things, they will be so much easier for everybody to work together. And then again, you will not be worried about, oh my goodness, I'm not collecting any money, or you have a large amount in ARs. Why do we have 2 million or whatever the case might be? So all of these things you have to take in consideration.
Spot on. I appreciate all of your knowledge and experienced insights here on billing. So yeah, I'm going to get a lot of feedback from this conversation. So I know that it's going to go over really, really well with my audience, because these tips were huge. So thank you for all of that. Now, I know it's going to be time for you to go. But for my last question here, this is what I like to ask my guests. You know what, Kate? What are you still planning to do in the next 5 years? What's your next big goal? What's your next achievement going to be in the next 5 years?
So honestly, if I had the opportunity, I would love work for APC. I think it's an awesome organization. It has evolved since I have joined it. They have so many new programs. They offer now online testing for CPC and a lot of help to get people certified and acquainted with the healthcare field. And they have, I believe the APC has just more programs than any other one that I have seen, including AMBA or AHIMA. Because AHIMA, I think they also focus more on, somebody who's working at the hospital.
The inpatient side, right.
The APC has variety, and that's what I like, because you could be a certified biller or a coder or an inpatient coder or an outpatient coder, and now they added more designation, cardiology and ENT or something like that. So I would love to work for them if I had that opportunity. But one of my other goals is to publish more articles for APC. I was excited about my article. The article that I published was about genetic testing trends. This is a topic, honestly, that I have not worked on previously, but I was able to capture the information about codes and reimbursement and the trend itself in the way that people really liked, the way it was written and the information that it gave. Because I believe that in that magazine, I have to tell you, there's so much of wealth of information in there. And when I'm looking for something, sometimes I can just go and click through and be like, oh, wait a minute. I have a physician who's doing, this particular procedure. And I was just looking for more information about it. So, and they will come up and they'll be like, all right, this is fantastic. Or whether it's ICD-11s, which by the way, they're coming
It's coming.
also,
Yep.
and they publish that information. So
Mhm.
I want to be part of that too and contribute more. So that's one of my other ones. And I want to present at the APC HealthCon. I never went. Unfortunately, every time we had it, um, I had to work or something else was going on, or we had the pandemic situation.
Pandemic. Yep.
So having to present, they're very selective from what I heard when it comes to specific topics. So I haven't even come up with a specific topic yet. So I'm trying to come up with something that people will want to do it. And that's one of my other dreams, is to physically go to a health con and present with my family, because my husband and my son also want to go there too, and just have the presentation and have the feedback also, because every time you present, you don't know how it's going to go, and having it physically presenting and or online, a lot of things could happen, and then you always try to get feedback. How was it? What could I improve and everything else? And then whether or not my topic contributed to helping somebody. I love when people see my presentations, the local APC chapters, and then they email me for more clarification about whatever other issues that they have in their office. And I have no problem. So here you go. You can contact me if there's something you don't understand. I can always give you a little bit more elaboration or attach a medical policy or something, or whatever the case might be. So that also is one of my other things in the next 5 years, to go to HealthCon and physically present. I would be ecstatic if that actually happens.
Well, I love it. I think you can achieve any one of these goals in the next 5 years. I know you can do it. It'll be
Thank
great.
you.
It'll be great. No, I love it. I love it, Kate. Now, before you go, you know what? All of my listeners might not be connected with you. So would it be okay if I posted in my show notes where they can find you on LinkedIn? Are there any other places you would like me to highlight for you in my show notes?
Yep, they can find me on my website for care2billing.com. And that's my blog, basically. You can find my services. I started to also do on demand, which is part of Thintific. That's the one that I found to be, the website is easy to use, and it's more interactive, and it's easier to upload the information onto. So I'm starting to kind of put the webinars together and have that on there too. On my blog website on care2billing.com, they can actually click on demand and they can actually go in there. I don't have anything yet, but that's one of the things that I'm going to do there. And I try to post, I haven't posted, I think last month I posted maybe 3 or 4 blogs, but anything new, whether it's telemedicine, telehealth, whatever other things that change that are important, I write the free blog posts. And then that is also on my LinkedIn account if anybody needs that. And then anybody can find that all the time. So that's where they can go to find me.
Excellent, Kate. Wonderful. I'll be sure I put all those details in my show notes. Thank
Thank
you
you.
so much for this amazing conversation. I've loved it.
You're very welcome, Sonal. Thank you for having me.
It's my pleasure. Thank you, Kate. And now it's time for my best practice tips in Trusty Tip. So in today's compliance tip, I wanted to focus on a new HCPCS modifier, FT. That's F as in Frank, T as in Tom. Now, this modifier FT is new and it's effective for dates of service on January 1st, 2022. Now, they've tweaked the original description in the HCPCS updates. So as of March 3rd, 2022, there was a HCPCS second quarter update that did in fact revise the definition of modifier FT. Again, that's F as in Frank, T as in Tom. Now, of course, be mindful, this definition is retroactive to January 1st, 2022. So it states, quote, modifier FT is defined as an unrelated evaluation and management, an E&M visit on the same day as another E&M visit or during a global procedure. And that means it's either going to be preoperative post-operative, or on the same day as the procedure as applicable. And in parentheses, they also tell you to report it when an E&M visit is furnished within the global period, but is unrelated, or when one or more additional E&M visits furnished on the same day are unrelated. Now, specifically to critical care services, right? This modifier should be used for critical care performed by a surgeon during a global period. However, the critical care must be unrelated to the procedure or the surgery that was performed. Documentation must clearly support the reason for the service as unrelated to the primary surgical event. Now, of course, this emphasizes that unrelated critical care warrants the use of modifier FT. F is in Frank, T is in Tom. Now, patients may require these types of critical care visits during the global period for a procedure or a surgery, whether this is preoperative or the same day or during the postoperative period. And let's be mindful, in some cases, in some instances, the CPT codes that have a global surgical period include the pre-op and the post-op critical care services already bundled within them, right? So we have to be mindful. Now, with this new release of updated policies, right, back in January of 2022, CMS provides authoritative guidance that explicitly states that Medicare does allow separate payment for unrelated critical care services that are rendered on the same day or rendered during the global surgical period. Now, proper reporting of these services includes the appendage of modifier FT. That's F as in Frank, T as in Tom, to the critical care CPT codes. Now, this is brand new, right? Brand new modifier that helps track all of these types of services. So start using your modifier FT if these types of situations apply to your practice. Now, of course, the key is in the details, right? And the most specific detail here is the word unrelated. So it has to be unrelated. And for Medicare purposes, to cover these types of services that are described by CPT codes 99291, which is, of course, defined as critical care, evaluation and management of the critically ill or the critically injured patient, first 30 to 74 minutes. And also that add-on code, right, for 99292 for each of the additional 30 minutes when it's performed before or after the surgery or on the same day as a procedure. Now, of course, be mindful that your documentation of those two services must be distinct. And then, therefore, the documentation should demonstrate how they stand alone and separate as well, right? And CMS continues to provide their guidance and help us understand how to use this new modifier correctly. So, based on the March detail and the March revision of the definition, when there are cases of a critical care visit that's unrelated to the procedure with the global surgical period, those types of critical care visits may be paid separately in addition to that global surgery, right? To that procedure, if certain conditions are met. Again, fine detail, highlight on the word certain conditions. So CMS will allow for payment for the pre-op or the post-op critical care in addition to the procedure if the patient is critically ill, right? That's the most important feature for the critical care services. The patient must be critically ill, which means they must meet the definition of critical care. And then, therefore, that requires the full attention of the physician, and the critical care is above and beyond and unrelated to the specific anatomic injury or the general surgical procedure that was performed. So, for example, you can think about things like trauma or in burn cases, right? In those types of situations, you should be appending modifier FT. F is in Frank, T is in Tom. So I hope that helps. So just remember, it's completely fundamental that if you have Medicare as a payer, to keep your eye on all of these revisions and updates and new things that happen throughout the year. We've seen plenty of changes as of January 1st, 2022, and this modifier FT is no exception. So keep your eye on correct and compliant coding and billing practices and make sure that you're adhering to all of them to ensure you are meeting all of those requirements from the very, very start. When the documentation paints the medical picture with clarity and with vibrancy from the onset of care, a certified medical coder can then abstract codes with accuracy. And finally, I focus Season 5 Spark on clarity and focus. I want this 5th season Spark to be filled with the world's thought leaders, all of our writers, all of our artists, our philosophers, everyone who inspires the need for clarity and focus in all that we do. So, in this week's inspiring quote in Spark is from author and motivational speaker Zig Ziglar. I don't care how much power, brilliance, or energy you have. If you don't harness it and focus it on a specific target and hold it there, you're never going to accomplish as much as your ability warrants. Absolutely true, right? I think this quote inspires us to really focus on specifics for change, for improvement. I think this quote reminds us that we cannot change everything we want to see transformed without clarity of vision. I am happy Zig Ziglar's spark still burns brightly in all of us today. So that wraps up today's episode. And as always, I appreciate you all diving into today with me. If you want more information from me, please go ahead and follow me on LinkedIn. I'll leave links to everything in the show notes below. Please have an amazing week ahead, and please continue staying safe and healthy. Thank you so much for listening in on today's very special episode, and I hope every week with me brings you closer to helping your providers paint a masterpiece. See you next Wednesday.